G'day, welcome to Emergency Medicine Topics in One Coffee. I'm Giles, an emergency physician, and today's topic is acute salicylate ingestion. Let's start with the illustrative case. There's a 49-year-old Cambodian lady who presents after she drank some rubbing herbal oil. What had happened is she had some mild abdominal pain and she was using the rubbing oil on her abdomen. When that didn't work, she thought, bugger it, I'll scull the rest of the bottle. Now the rest of the bottle was about 15 mils. At triage, the nursing staff rang poisons information and they said that this rubbing oil was 98% oil of wintergreen. Now, oil of wintergreen is a methyl salicylate, and 1 mil of it taken orally is the equivalent to 1.4 grams of aspirin. So if you think about it, 15 mils is equivalent to about 21 grams. That's 300 milligram tablets taken in one gulp. So what's she like? Well, it only happened about an hour ago. She's drowsy. GCS is technically 14. She's got a respiratory rate of about 32 per minute, although her saturations are 98% on room air. She's tachycardic at 110 per minute. Her blood pressure is 100 systolic, and she's got a mildly tender abdomen, but it's not surgical. Okay, so her body weight was about 60 kilos. So since she took 21 grams, that's about 350 milligrams per kilogram. Less than 150 milligrams per kilogram of aspirin is considered, not particularly toxic. It's only quite mild. At 150 to 300 milligrams per kilogram is considered moderate toxicity. Above that is severe toxicity, getting to greater than 500 milligrams per kilogram orally, considered potentially lethal. So with her, 350 milligrams per kilogram, that's a solid dose. Okay, so what should we do? What do we expect and what can we put in place? Well, first of all, let's just go through some of the pharmacokinetics of salicylates. Okay, so salicylates are absorbed pretty quickly. Peak levels, 2 to 4 hours. Now, understandably, it's faster with oil of wintergreen and it'd be slower with enteric-coated aspirin. Next, it binds avidly to albumin, but when that albumin's all bound, a small increase in dose orally causes a rapid rise in the free salicylate level. It's got a low volume distribution, 0.1 to 0.3 litre per kilo. It's broken down by the liver and it's weeded out by the kidneys. Now with a small volume of distribution, in the back of your mind you think hemodialysis, even if it has high protein binding. Lastly, it's got a pKa of 3.3. Remember the pKa? That's the pH when both the ionized and the unionized form are equal. So with someone with a pKa of 3.3, if you've got a pH of 7.4, 99.99% is ionized. This is important because if you alkalinize the urine, it will hold the acid in an ionized form. Therefore, you'll promote excretion because the ionized form can't be resorbed by the tubules of the kidneys. So, what do salicylates do to you in overdose then? Well, it causes direct stimulation of the respiratory center, and we can see in this lady she's got an increased respiratory rate. It also uncouples oxidative phosphorylation. It sounds bad, doesn't it? It is. Now, if you recall, oxidative phosphorylation is a complex system by which glucose, fats, amino acids are broken down using oxygen and eventually, following an electron transfer, create ATP from ADP. And that ATP is then used for multiple chemical reactions all throughout your body. And for every molecule of oxygen used, about 3 ATP are formed. Now, when salicylates uncouple oxidative phosphorylation, you get less ATP formed. You need more substrate going into this inefficient engine. You need more carbohydrates, fats, amino acids, and oxygen going in to make that ATP. And being inefficient, you make more heat and carbon dioxide. It's really like making an inefficient engine. More in, more oxygen, more heat and CO2 created. I think it's the best way to remember it. Okay, let's anticipate what's going to happen to this lady as her salicylate level rises and what we can do. Now, we'll need to get intravenous fluids in. She'll be vomiting this, and she'll get hypothermia, so she'll have more insensible losses, so we'll need to get some IV fluids. She'll have that respiratory center being stimulated, so she'll initially get a respiratory alkalosis, but then she'll develop more of a metabolic acidosis for multiple reasons. We've inhibited pyruvate dehydrogenase, creating more lactate. We've, of course, creating ketone bodies, and salicylic acid, salicylate salicylic acid, is an acid in itself, so we've got multiple reasons to get metabolic acidosis as that salicylate level rises. Now, of course, the elevated temperature, I wouldn't treat it with an antipyretic like aspirin, perhaps use paracetamol. As you're using more substrate, such as those carbohydrates you use to your inefficient engine, your glycogen, it's been broken down, and you could get hyperglycemia and glycosuria, but also you could use it up, especially in young children, and you have to keep an eye out for hypoglycemia. As the level rises, you'll get more central effects, agitation, delirium, and even seizures. The seizures should be treated with benzodiazepines, midazolam, 0.1 milligram per kilogram, IV, IM if you have to, as an initial thing to stop the seizures. And you may have to intubate them, especially if they've got repetitive seizures, non-cardiogenic pulmonary edema, or decreased level of consciousness or agitation. You may need to intubate it. Be careful about this. Try and get them as euvolemic as possible, because when you intubate them, you're going to get positive pressure and induction agents, and you could suddenly crash their blood pressure. Also, remember, they've been breathing up. They've got that respiratory stimulation, and they've got a respiratory alkalosis, even if they've got a worsening metabolic acidosis at the same time. So you'll need to have repeated venous blood gases, and when you intubate them, make sure you keep up their minute ventilation. Because if they're breathing quickly and you've decided, oh, I've intubated them and I put them on 700 mils per breath, 14 breaths per minute, that's much less than their minute ventilation was before. Their CO2 will rise, and suddenly they'll get a worsening respiratory acidosis as their CO2 rises, and you'll end up with someone who'll have worsening pH and have some real end organ problems, could find yourself in some real difficulties. Okay, a few words about salicylate levels. Look, they're useful for trends, but they pretty poorly correspond to any level of toxicity. So the basic treatment in summary: IV fluids, bloods, watch for high and low glucose and especially low potassium. Get regular venous blood gases, looking to see how the trends of that respiratory stimulation and the metabolic acidosis is occurring. Link into intensive care early. Watch and treat that hypothermia. Check your salicylate level trends. Treat the seizures, as we said, with benzodiazepines, and predict the requirement for hemodialysis. Now, unsurprisingly, this is done when the patient shows severe toxicity, CNS effects like agitation, seizures, severe unrelenting acidosis, non-cardiogenic pulmonary edema, and especially if they develop renal failure, as they won't be able to clear the drug. One question is asked is, should you use activated charcoal? Look, I'd only use it if they'd taken more than 150 milligrams per kilogram. That is, that they've actually got some significant toxicity, that they weren't vomiting, and that they had a protected airway, and it was occurring in the first 6 hours. So that really does cut down the numbers. If you have them intubated and you've got a nasogastric tube down and that unwell, yeah, I think that's reasonable to give some activated charcoal. I think we mentioned alkalinising urine once. Sure, use 8.4% bicarbonate intravenously, start at a mil per kilo to do it, to enhance that elimination. But try and make sure you've got them as close to euvolemia first before you alkalinise their urine. So you'll get advantage from a linear relationship with the volume of urine you've got if you keep them euvolemic, and your logarithmic advantage if you're able to alkalinise the urine after that. A nasty little overdose. Okay, to finish, what happened to that Cambodian lady? Well, she got worsening respiratory alkalosis and worsening metabolic acidosis. Her pH dropped to about 7.06 at one stage, and her salicylate level got reasonably high at 6.6 millimoles per litre. But she managed to avoid being intubated or getting hemodialysis, and after about 2 days was discharged from intensive care and was discharged from the hospital unscathed. Well, I think that'll just about do for acute salicylate ingestion in one coffee. I'll see you all next time. Cheers.